This presentation is part of the NDS Safer and Stronger project, which focuses on supporting disability services in response to COVID-19. We are joined by Teresa Desmond from OC Connections, sharing how her team handled a positive COVID staff member.
If you have to have a positive COVID case, ours was the one to have. So I just want to acknowledge that there are a lot of other providers out there that have had perhaps more serious cases. As a small provider, we were very lucky. We had prepared, no doubt about it, but we certainly have learnings as well. And we managed to contain it to one person. So there's a lot of luck in that, thank goodness. At 6 p.m. on Saturday, the 8th of August, a staff member called on the on-call line, and she was a day support staff member, to advise that she had a positive COVID test. She'd last worked in our day support on Thursday the 6th, because on the Friday she'd actually felt unwell, done absolutely what we asked staff to do and not come in. She had worked the Wednesday and the Thursday and had been all over our building on that day, interacting with people. So to set the scene, we had prepared, and I know every other provider has as well, but we had an infection control group that we established in February. We have business continuity plan, infection control framework, a COVID action plan, which is constantly reviewed. The thing that I think made a very big difference to us is that we had all of our staff in PPE pretty early in July. And that's because a number of our participants with intellectual disability can't social distance. So as a safety measure, we popped staff in PPE. They probably didn't like it and they're very happy wearing it now, which is good. We also implemented training for PPE, March, April, again in June. And right now we have a coach working with people just to see that everything's okay and that practices are right. And it's amazing what that person has picked up where we've breached. We'd also conducted desktop scenarios to plan for an actual COVID case. And we'd done that with our infection control group, but also our business units. So our employment division, our community living or our accommodation program, and our day support program had also done small exercises just to see how they would go and what they would do. From early on, every person that had any symptom was treated as a COVID positive until their test came back negative. And predominantly, and I say that because you understand that you can't always do it, we've had a one site, one staff member policy since March. We went back and redid all of our rosters. There are instances where we can't, but in most cases, and where we can, we do. People stay on one site. And in addition to that, we worked out that back in April that we had 36 staff working across other employers. Now, they're not all disability or aged care providers. Some of those are very low risk, such as Harvey Norman, but we actually know where staff work and who they work with, and that's been helpful. So what are our learnings? There are many, and I'm going to go through them pretty quickly. But the first big mistake was to get the close contact sheet right the first time. We actually put too many people on it the first time and found, frankly, that it's almost impossible to alter it. So our first contact with the rapid response team in public health was on the Saturday night. And so 3 weeks later, people that were on that close contact sheet were still getting contacted by them despite us asking them to remove them. So that is an issue. Get your close contact sheet right. The definitions are clear. We were far too generous. Responses take time most times, and I think you need to allow for that. So often in our experience, public health and rapid response needed to escalate to a manager, so we didn't get an immediate response. Expect to provide information to parties notified more than once and for weeks. And it was only yesterday that we had contact from one of the powers that be, and we had to respond again 3 weeks after the event. But now I believe it's closed off, so that's a blessing. But the information is repeated, and expect to repeat the information to every party, because those parties often can't share information. So one of the big learnings for us is, yep, we had the information, yep, we had it in one spot, but we actually will now get it much more succinct and easier to manage so that people can answer the same question again and again. The thing for me that I found the most frustrating is don't expect to be guided with best practice protocols. And in this case, I felt that we didn't get advice, and we still haven't. So you've got to be prepared to make your own decisions regarding participant and employee safety. What I'm specifically referring to is that our contact was in our day support service. My question was, how long do we need to close for? So we got our deep COVID clean without question. We had that ready and we implemented it on the Sunday. What is the best practice protocol? How long do you need to close? I think we ended up closing for too long, but to this day, I still haven't been told what is the best practice protocol for length of closure. We closed for 2 weekends and 5 full days. I think that was too long in hindsight, but to be honest, I still haven't got an answer to the question. The other thing is different messaging. So the close contacts, which ended up being the correct list, was 4 staff and 1 participant, were given different messages. The individuals were given different messages about return to work. The positive person was told in writing she could return to work without a further test, and yet she still had a dry cough. So we actually asked her to go and get another test and to wait until that dry cough had gone. Now, I am no medical expert, but we felt that that was the most conservative and safest approach. She'd also been told by somebody else that she had to wait to be 3 days symptom-free. So we actually took the conservative approach and went with that, which I think was a much safer way to go. The thing is that I think internally you need to have your infection control group and talk it through because of the information that comes through, which is sometimes different. Communicate with the world, verbally and in writing, frequently, and to all stakeholders. We also needed to speak with other providers. There was 3 other providers where some of our day support staff who were not close contacts worked. And so on the Sunday, because of I actually spoke to 2 of those providers. I didn't speak to the 3rd because the person concerned hadn't worked there for a week. So we don't have any protocols around that as a sector, but I did speak to those people, and I know they actually asked their worker to get a test. So that's good relationships, I think, very important. We had people stepping up and wanting to help. I've heard contrary stories, and I'm sure that will happen to us, but we were very lucky in that people stepped up, worked extra, and wanted to help us sort this through. PPE did help us. We had PPE on, staff were all wearing it, and as a result, I would suspect that that is what saved us spreading it, because you'll recall that the person was walking through our building, working with clients, working with families for 2 days prior to diagnosis. So PPE, thank goodness. It's relentless. We had a minor case, but it's tiring, it's stressful. Support, support, support. Post that, we have always had an EAP program, but we've actually implemented wellness and wellbeing seminars for all of our staff that they can access, and they are, the uptake's really good. So I figured that they must need them, and it's great. And the other thing is, of course, review what you've done, which we have done. We've made mistakes, we've worked out what they are, and we've reviewed our documentation and our checklist to try and pick those up in the event that we get another COVID case, which I certainly hope we don't.